the four speakers.
So good morning, good morning, everybody. It's a pleasure to be here in Delhi. This morning I'll be speaking on stimulating catheters in regional anesthesia practice. And before I begin, I just wanted to extend my greetings from the city of Hartford. That's where I practice. Hartford, as you know, holds a very special place in the history of anesthesia. It was in Hartford that Horace Wells, a dentist, used nitrous oxide for the first time clinically on patients. And these are some of the monuments that honor the memory of Horace Wells in our city. So why use catheters? The obvious reason is to prolong the duration of the block. And you also have the ability to titrate the intensity of the block so that when patients are scheduled for physical therapy, you can decrease the intensity of the block so patients have more functional ability. And when they are, and at night, you can intensify the block so that they can have a good night's sleep with good analgesia. And with superior pain control that nerve blocks provide, it is easy, you can see how we can decrease the use of narcotics and the opioid-related side effects, especially nausea, vomiting, sedation, respiratory depression, and some of the other side effects that I've listed in the slide. The technique for putting in a stimulating catheter is fairly straightforward. So you first have to insert a needle next to the target nerve, and you can use either nerve stimulation or ultrasound guidance to be able to put the needle tip close to the nerve that you want to target. In my practice, I use a combination of nerve stimulation and ultrasound guidance. You then thread in a catheter, which is attached to a nerve stimulator. And the challenge is that as you advance your catheter, you have to be able to maintain the nerve twitch, which tells you that your needle tip, your catheter tip, is in close proximity to the nerve that you want to block. And the third step is that you have to inject your local anesthetic through the catheter. And that's an important distinction between the other technique where you actually inject your local anesthetic through the needle and then blindly thread your catheter. With the stimulating catheter technique, you inject your needle, you inject your local anesthetic through the catheter itself to induce the block. The question is, why use stimulating catheters? And in my mind, there are two important reasons. One is precision, because you have an objective endpoint with the muscle response that you elicit. You can precisely place the needle tip or the catheter tip where you want it to be. It's just like landing a plane on a runway. You have to have that precision. The other reason is that it gives you a lot of reassurance. If you induce your block through the catheter, so you inject your local anesthetic through the catheter, induce your block through the catheter, you can then rely on your catheter. It gives you a lot of reassurance. There's a lower risk of secondary block failure, and the quality of analgesia is superior. There are some disadvantages as well. It may take longer to place a stimulating catheter, especially when you're learning, when you're starting out using these catheters. As I mentioned earlier, the challenge is that when you thread in your catheter, you have to be able to maintain a muscle twitch. And if you advance your catheter and you do not get a muscle twitch, then you have to manipulate either the needle, and your catheter needs to come in and out multiple times. So it may take you longer to place it. Also, if a patient has a lot of discomfort, if you're placing a catheter in an extremity that is injured or has a painful condition, when you elicit those motor responses, it may be uncomfortable for the patient. And obviously, these catheters are slightly more expensive than the regular catheters that you have to place. So these are some of the disadvantages. So what I decided for the next part of this talk is to actually show you a lot of videos, and that will illustrate how these catheters are placed. And as the videos go along, I will give you practical tips that you can use in your practice. So we'll start off with the interscalene catheter. So you can see the patient is sort of positioned in a slightly lateral position with a roll of blankets under the shoulder. You have to maintain good sterile technique anytime you place a catheter. The needle that the TUI needle that is inserted initially, it's a fairly big gauge needle, about 17, 18 gauge TUI needle. So you really want to infiltrate the tissues really well through the planes through which the TUI needle is going to go. So that's the TUI needle being advanced to the target nerve. The target nerve is right here. And as the TUI needle comes in close proximity to the nerve, we then turn the stimulator on, and in this case, we get a deltoid twitch. You need a third hand when you're placing catheters with ultrasound guidance, so you use the help of your assistant to be able to hold the transducer while you thread in your catheter, and you manipulate the needle and the catheter. And as I said, as the catheter is advanced, you can actually visualize it under ultrasound guidance, so it gives you feedback as to what your next move should be if you do not get a twitch. And once you have threaded the catheter, usually 3 to 5 centimeters beyond the tip of the needle, you should be able to elicit brisk contractions through your catheter. The catheter is then removed. Anytime you place a catheter, they have to be secured really well. In our case, in our practice, we tunnel all the catheters. And you have to use some kind of a mechanism to tape the catheter in place. Again, in our practice, we use tincture benzoin, steri-strips, and tegaderm. And as you inject through the catheter, you have the ability, if you're using ultrasound, to be able to see the spread of local anesthetic around your target nerve. And as we inject, you can actually visualize the spread of local. So there's the steri-strips. And then we place our catheter. So moving on to the next, a femoral catheter. Now in this we use an out-of-plane technique. And when you use an out-of-plane technique, you have the ability to hold the catheter and the transducer with one hand, so you really don't need somebody else's assistance. As you can see, we are holding the needle as well as the transducer with the same hand, and you don't need the third hand. Also, because in an out-of-plane technique, you really don't see the shaft of the needle. All you see is tissue movement. And as you advance our catheter, we are able to maintain the quadriceps twitch. Again, we tunnel the catheter. A lot of it is going to be repetition, but I think it's important for you to see these different techniques so you can use parts or all of it in your practice. Again, we tunnel all the femoral catheters. As I said, we tunnel every catheter that we place. These catheters usually stay in place for 2 to 3 days post-operatively. And sometimes patients go home with them. So you want to be very sure in how you affix them. You have the ability to stimulate through the catheter once the catheter has been placed. Once the needle is removed and just the catheter remains, you have the ability to stimulate through the catheter, and as you inject your local anesthetic solution, you can see the spread, and you have the abolition of the muscle response, and that's your positive Raj test. Moving on to a popliteal sciatic. For this, we have the patient in a prone position. What is important is that the foot and the ankle should be hanging from the edge of the foot end of the bed, so you have room for the foot to twitch as you advance your catheter, and that is an important point. Again, you can see the common peroneal and the tibial nerve as they come together to form the sciatic. And then in this case, what we did was we rotated the transducer, so you can actually now see the nerve in a long axis. And in this case, we positioned the catheter in a long axis plane. Again, very generous infiltration of local anesthetic through the tissues through which the TUI needle is going to travel. As you bring your needle close to the nerve, you should be able to elicit the motor response. There is the needle coming in close proximity to the nerve. And as you get close to the nerve, you can then turn on your nerve stimulator and elicit a motor response. And as you thread in your catheter, you should be able to maintain the twitch as you advance the catheter. And as you inject your local anesthetic, you abolish your twitch response, and you can actually see the spread of the local anesthetic solution. Now, in interest of time, I'm just going to skip ahead. I will skip the infraclavicular block and just go to, I'll summarize the practical tips. So sterility is important. When you need a third hand, use your resident or your assistant or a nurse who's helping you to hold the transducer from under the drapes so she can be unsterile, but the sterility of the field can be maintained. In terms of threshold current, what we do is we set our nerve stimulator box to a current of 1 milliamp and then leave it. We don't touch it. We don't try to optimize our current to 0.5 or less. We just leave it at 1, and the needle as well as the catheter are inserted at 1 milliamp. And we found that to be a reasonable compromise in terms of not wasting a lot of time in trying to optimize the current at which you stimulate a motor response. And you can sort of move rapidly through your steps. If you want to use a little bit of a liquid or a fluid to dilate the space before you thread in a catheter, use D5W solution, because with the D5W you still have the ability to stimulate through the catheter. What about the evidence? For stimulating catheters, when you compare stimulating catheters to surface landmark-based technique in a semi-quantitative review in 11 randomized studies where they used about 650 patients, what they found was that the stimulating catheters provided better analgesia. When you compare ultrasound guidance to stimulating catheter, you lose some of that advantage. With ultrasound guidance, it takes much shorter time to place the femoral catheters, and there's lower risk of vascular puncture. Similarly, for sciatic nerve, same thing. Ultrasound allows you to place the catheters faster. There's no difference in pain, satisfaction, and block success. Similarly for popliteal sciatic, there's less time, 5 minutes versus 10 minutes, as opposed from ultrasound versus surface landmark-based stimulating technique. For interscalene, similar results. So when you use ultrasound guidance, you lose some of the advantage that you have. But in my practice, I still continue to use both the techniques. So in summary, stimulating catheters are better when you compare it to surface landmark-based techniques, but you lose that advantage, as I said, with ultrasound when you use ultrasound guidance. With ultrasound guidance, you can place the catheters in a much shorter time. You have equivalent success rate, and your risk of vascular punctures or injury to adjacent organ structures are less. But my personal bias is that I continue to use ultrasound guidance and stimulating catheter together. Thank you.
Thanks, Dr. Sinha, for a very lucid. I think we are going to keep the discussions at the later part of the session. I would like to know from organizers whether the first speaker has come.
Yes, sir, he has.
Okay, so we'd like to invite Dr. Sean Flack from USA. He would be speaking on high-resolution ultrasonography. So we welcome Dr. Sean Flack. The limitation of bandwidth, the limitation of sensitivity. So let's invite Dr. Sean Flack, and who is going to speak on high-resolution ultrasonography.
Good morning, everybody, and my apologies for stressing the coronaries of the moderators and being late this morning. My talk is entitled High-Frequency Micro-Ultrasound, and in contrast to the previous talk, I'll be describing a technology that's not currently in not currently in clinical practice at all, but is certainly something that is emerging and is currently used in preclinical settings and will be commercially available in the not too distant future. I do have a disclosure that this presentation describes work done in collaboration with Sonosite. The machine that Sonosite has is called the Vivo 2100. And what I hope to do is just remind you briefly some physics of ultrasound, just to put high-frequency micro ultrasound into context, to describe a little bit of our clinical experience, and then to offer some thoughts about what the utilities of this new technology might be. So remember that transducers are devices capable of converting energy from one form to another. And the transducers in ultrasound probes convert electric energy to acoustic ultrasound energy, and then convert ultrasound energy back into an electric energy. And it was Jacques Curie in the 1880s who first applied energy to quartz and demonstrated that this caused vibrations, and that the opposite is also true. Vibrations are converted by quartz crystals to energy. So the transducer probes that we use have an array of piezoelectric crystals, and they both emit and receive the ultrasound waves. What's important to us as clinicians is the quality of resolution that we get when we perform ultrasound. And there are two types of resolution. There's axial resolution and then lateral resolution. Axial resolution is the ability to discern objects in line with the axis of the ultrasound beam. And the axial resolution of an ultrasound wave is dependent upon the frequency of the probe. So what you see here is two objects in line with the probe, and the green waves are a low-frequency probe, and the purplish waves are a high-frequency wave. And because the distance between the ultrasound waves and the low-frequency probe are greater than the distance between the two objects, they will be interpreted by the ultrasound machine as a single object. Whereas with a high-frequency ultrasound, the waves do not overlap when they return to the ultrasound machine, and so the machine interprets the objects as two separate objects. Lateral resolution is a little different. So this is the ability to correctly display two objects perpendicular to the beam as separate structures. And it depends on the relative distance between the piezoelectric crystals. So the more piezoelectric crystals you can engineer into your probe, the better the lateral resolution will be. So again, if you have two structures and they fall within the single beam of a piezoelectric crystal, they will be interpreted as a single structure. Whereas if the two structures fall outside the beam of the piezoelectric crystal, they'll be interpreted as two structures. The clinical ultrasound machines that we currently use are typically 12 to 15 hertz machines, probes. They have approximately 125 crystals in a probe, and the resolution is down to a 200 micron level. Now, the high-frequency micro-ultrasound machines operate at a higher frequency, obviously, from 15 to 50 hertz. The probes contain far more crystals of the order of 250, which is a real engineering feat on the part of the engineers who produce these probes. And the resolution is all the way down to 10 microns. Now, remember, a red blood cell has a width, a diameter of approximately 8 microns. So these machines can actually ultrasound individual red blood cells. Now, up until now, they've been really just used in preclinical settings. And these are some pictures showing how researchers use these machines. This is a 12-day-old mouse embryo in utero. And you can see the lateral ventricles of this embryo. You can see cardiac structures. You can see the amniotic sac. It's really quite remarkable. This image is a circle of Willis in the brain of a 12-day-old mouse fetus. This image down here is the carotid artery, also a 12-day-old mouse fetus, and you can see the bifurcation into internal and external carotid arteries. These are some pictures from Seattle Children's of the machine in use. You can see the probe is quite large and clunky, and so not all that easy to use. In the preclinical setting, these probes are fixed in a mechanical arm, and the small mouse or animal that's being imaged is actually moved by a device underneath the probe. The probe doesn't move, so these probes were not really designed to be held by human hands. And you can see the machine itself is a very large machine, so a washing machine size machine. This is an image of a radial artery in the short axis at a depth of about 5 millimeters. And what you see is a shadow created by the arterial needle that we're planning to insert. We've laid the needle underneath the probe to create a shadow, and then move the needle until that shadow lies directly over the artery, and then we know we're in the correct position to advance. And that became a technique that worked well for us with this machine. This is an image of the neuraxis of a neonate. The depths you can see here, 8 millimeters down to 2 centimeters. The epidural space, 1.5 millimeters in width, is beautifully demonstrated with this high-frequency micro-ultrasound. And another image of the neuraxis prior to placement of a paravertebral block in an infant. Again, the depth, to orient you, 2 centimeters. So a beautiful view of the thoracic cord. We've identified the spinous process, so we know where the midline is. And then we've used the calipers, the measurement calipers of the machine to measure the distance from the midline to the paravertebral space and the depth to the paravertebral space, and then we know exactly where to insert our needle through the skin and how far to advance it. So I'm going to exit the presentation and show you a couple of videos. They cycle quite quickly. The first 3 videos are radial artery. Initially just the artery in short axis and long axis, then the radial artery with a needle and then a guide wire. There's some spinal neuraxial images. There are some images of an ilioinguinal nerve block, a rectus sheath block, and then a intraneural injection of a median nerve. So I'll cycle through them, and we can cycle through more than once. So that's a view of the radial artery at a depth of 4 millimeters in the short and long axis. And now an image of the needle entering the radial artery, and then the next image is the guide wire within the artery. That's an internal jugular venous line, some images of the neuraxis. You can see the blood flow next to the cord. This is an ilioinguinal nerve block, and you can see the nerves in the plane, and now advancement of a needle, and injection of local anesthetic. This is a rectus sheath block for an umbilical hernia repair. You can see the local anesthetic distributing. That's a very small amount, just a millimeter. And then this is a median nerve injection, an intraneural injection. So I'll run through those one more time now that you know what you're going to see. Radial artery, Seldinger technique for arterial line placement, needle, and then wire through the needle. Central venous line in the short axis view. Very quite striking images of the neuraxis. Again, the ilioinguinal nerve block. This is transversus abdominis, internal oblique. And then fine rectus sheath block. And one of the investigators, out of curiosity, had another investigator perform an intraneural injection of his median nerve just to see what it would feel like and what the clinical effects would be. He then went and tied a tourniquet around his index finger to see whether ischemic pain broke through, and he was happy to report to our surgical colleagues that ischemic pain does break through. And I'll let you guess which investigator that was, Manoj. All right. Last couple of slides here. So what's next for high-frequency micro-ultrasound? Well, as you can see, the images were a little bit grainy. There are some software revisions that needed to be made to really make the images more clinically useful. Some probe modifications to make them smaller and lighter and easy for a clinician to use. And I'm told that the 50 hertz probes will be clinically, commercially available in the not-too-distant future. What do I think the utility might be for this technology? Well, certainly imaging in the sub-10 millimeter range, where our current machines are not very effective, is an area where this technology excels. So potentially vascular access, arterial cannulation in small infants and neonates, difficult peripheral venous access, central venous access. And then regional anesthesia, again, I think where it may be useful is shallow nerves that we can't currently see with the technology available to us. So I think of head and neck blocks, perhaps distal foot and ankle blocks, penile blocks, and there's been some talk about subperineurium injections. And with this technology, we may well be able to visualize the architecture of nerves to such an accurate degree that becomes a clinical reality. Time will tell. So thank you very much for your attention, and happy to answer any questions at the end.
Thank you, Dr. Frank. We'll have the question session at the end of the fourth lecture. And we move on to the next lecture, which is about the stimulating catheters technologies by Dr. Amjad. I can't read the small one. Dr. Amjad from Bangalore, please.
I think with the GPS, that is Global Positioning System, just around the corner, we are all using this technology for guiding ourselves while going through the cities, streets, the navigation on our mobiles. So it's very useful technology. Let's see how the needle guidance or the guidance available as far as ultrasound is concerned helps us to guide us to the structures where we track to the target and go right back to the structure where we want to deposit the drug quickly and efficiently. So we'll ask Dr. Amjad Maniar to please go ahead.
Thank you, sir. Good morning, everybody. Today's topic that I've been given is newer needle guidance technologies. Greetings from Bangalore. We're going to be the host of the next AORA, so I hope to see you all there. I have nothing to disclose. Right, how many of you do ultrasound guided blocks? Can you guys put your hands up? And you all might know that imaging the nerve is one problem, but imaging the needle while you're doing the block is another problem. When you can see the needle very well, and then you can get the block done that way, things look very good. But we also know that you do require a little bit of skill to do this, okay, and a little bit of technical understanding. But then even having all the skill in the world, all the knowledge in the world, would put you to shame if you encountered a rather large patient where you have very steep needle angles. So Brian Seitz studied novice behavior associated with learning ultrasound guided blocks, and of 520 blocks, 43.7% of the errors were based on basically needle not being visualized while being advanced. So why does this happen? It's usually we're trying to do a lot of things at the same time, look at the nerve, angle things up, inject the drug, align the needle. So some of us don't coordinate this very well. Some of us don't really understand the basics of how you can image the needle to get a good view. And of course, if you encounter a patient who has a very deep nerve, there's really not much you could do about it. There are certain factors that influence this visibility. The first one is correct technique, correct methodology in doing it, and you can get a good needle image. The other is the kind of needle that you use. Today you saw me using an echogenic needle. Some of these needles can actually help you when you have a difficult block. The third factor, which I'm going to stress upon today, is the machine itself. We're going to look and see if the machine can actually help us get a better image going. Just a few concepts for you to know if you are new to ultrasound. Remember that even though the probe is big and fat and things like that, the ultrasound beam that comes out is just 1 millimeter thick. And your needle is less than 1 millimeter thick. And the whole skill here is trying to align these two together under 2, 3, 4 centimeters of tissue. The problem actually starts with needle angulation. Now, the visibility of the needle deteriorates usually after about 30 degrees of angling. Now, if the ultrasound beam is directly perpendicular to the needle, you get fantastic images. But this is not always possible in a block situation. Normally, you would see the needle at a slight inclination, and it's just pretty much good enough for us to finish the block. But what happens when it gets really steep? You see that the needle doesn't show up very well. That's because the ultrasound beam begins to scatter. The information doesn't go back to the probe for it to generate a nice image for you. So can we have a better needle? I'm not going to spend too much time on this. The echogenic needle is commercially available these days. The morphology of the tip varies. You can have a 2E, you can have a facet. But the whole concept is there's a little bit of etchings and engravings on the needle which create irregular angles for the ultrasound beam to reflect off. But even then, if you have all the skill in the world and you have the best echogenic needle in the world, you can't get this needle image going 100% of the time. So can the machine help us? And that's what we're talking about today. We're looking at certain concepts. Some of these machines are not available. Some of them are already available commercially. So we're looking at newer technologies and 3 concepts actually. The electronic beam steering, electromagnetic and magnetic tracking systems, and optical needle tracking systems. So this electronic beam steering, the first one. This is commercially available. Many of you may actually have it already on your machine. Okay? It's a software-driven technology. Remember that. It's nothing fancy. It's just software which changes the angle at which the ultrasound beam emanates from the probe. This is done by introducing a set of time delays into the transmitted pulses across the elements within the probe. And this has been around for a while. It's traditionally been used to highlight structures on the side by the radiologists. So schematically looking at it, the ultrasound signals would usually travel vertically with a fixed set of time delays, and this would give a straight beam. But if we were to introduce a little bit of time delay among the signals, the beam would slightly slant to the side. Okay? This works the other way around too. Now, you remember that needle that we couldn't really see too well? That's because the beam isn't perpendicular to the needle. But what the beam steering does is, it shifts the beam to look slightly more perpendicular to the needle, and this highlights the needle. So it's a very simple concept. It's re-angulation of the ultrasound beam. And this is what it would look like. This is an image of a regular needle without beam steering technology. But when you turn on the beam steering technology, the needle lights up. Okay? You do have certain other options based on your system. This is just one manufacturer. So you have the ability to flip the image, flip the beam steering in case you're coming in from the other side. And you have the option of changing the trajectory of this beam. So really there are a few advantages of this. The main thing being it's a very simple concept. It does not require any special hardware. It's usually done by a software upgrade on your system if your manufacturer supports it. You can use your regular needles with this. There's no need to have a specialized needle. And the main use here is using it when you have a very steep slant of your needle and targeting a very deep structure. Disadvantages is you still require some basic alignment of the probe with the needle. If you can't be way off target and expect it to light up. And if you don't, like once again, if you rotate the probe, you're going to get only parts of the needle highlighting. You may not even see the tip sometimes. The tip definition is a little iffy with this technology. And with an out-of-plane technique, you really won't get the angles required to highlight the needle. The next technology that I'm going to talk to you about is electromagnetic needle tracking systems. Okay, this is a nice looking ultrasound machine, a typical machine, but if you notice closely, there is another appendage attached to it. I'll tell you what this is. So basically an electromagnetic needle tracking system, it's a navigation system that is based on measurements of electromagnetic fields with a known distribution. When you place an object inside this field, varying magnetic field voltages are induced in the sensors available. And these essentially voltages allow you to define the position and the orientation of the object. Now, apart from the regular ultrasound hardware, there are some other components of the system. This is an electromagnetic field generator. The needle system is a little different. They have their own proprietary needles because you have to integrate a sensor into the needle. Okay, so the sensor is a reusable device there, and the needles are rather thick. This particular manufacturer has a 19 gauge needle, so that's a minimum gauge of needle that you would be using. And of course, the probe, though structurally similar, incorporates another sensor. So these are all motion sensors. So if you look at the image, the transmitter generates a magnetic field of known dimensions. There are sensors in your needle. There are sensors inside the probe. And as you move the needle and the probe, which is what we always do, the system tracks where you are. And it is able to overlay this image of the needle and the ultrasound together and give you an image where the needle is a virtual object. I'll show you what it is. So this is the basic setup of how it would be. The generator, the probe, and you see a rather large needle there. So that's the electromagnetic field that would be generated. So this is how the image would be. Now this is not your typical ultrasound image. you're going to wonder where the needle is. There is no needle anymore. What is drawn is a virtual needle. You see the red here. And the green line signifies the trajectory that the needle would take if you were to advance it in this direction. X marks where the needle tip would be. Okay? The machine also gives you a graphical representation of where your needle is. Are you angled in plane or are you angled out of plane? So you can see here that the needle is somewhat off out of plane in relation to the probe. So this is a video from the manufacturer entering a phantom. So you can see this targeting this structure, and you can see the needle being going. So this is a very nice concept. It has certain advantages. The main thing is you can actually predict the trajectory of the needle without entering the skin. That is, you can aim the needle at your target by just waving the needle outside. And rather than manipulating the needle inside tissue and causing a bit of trauma here, there you can actually predict your path. So does it require any skill? No. Absolutely not. This is a very simple way to do a block, minimum skill required. And our concepts of needle probe alignment, the in plane, out of plane, these are all not valid here anymore. You just need to aim and just push your needle in. Disadvantage, again, these are expensive machines, high-end machines, not really well available, and the needles are definitely different. The electromagnetic field is prone to disruptions if you have a lot of metallic objects nearby or phones and equipment going. Not universally available. And we might just lose everything that we have learned if you use these needles. The in-plane, the angling, all those things that we have learned so far may just disappear. Has it been used in clinical practice? Yes. Dr. Kamakar might have seen this. So this was exactly what he did today in the workshop, but this was done using the GPS needle, and they were able to predict the trajectory without entering the patient's skin, and they parked the 19-gauge needle near the ligamentum flavum, and they put in a long spinal needle and did the spinal block. So this is possibly one place where we could regularly use this sort of system. The next system would be something called magnetic systems. So magnetic needle tracking, again, this is similar images to what you saw, but it does not have the electromagnetic field generator. So it only needs a needle guide with a magnet, and the probe has magnetic sensors which determine where the needle actually is. And this is overlaid onto the ultrasound image. So the components are a little different. You have a rather oddly shaped probe here. It's not your typical, this is the handle, and this is the footprint of the probe. The blue structures you see are actually reusable probe covers, which you can use to maintain sterility. And the needle incorporates a magnet. You see that round thing there? The needle incorporates a magnet which goes through the bracket. Now the probe also has magnetic sensors on the side. So when you advance in, you can see that the data is interpolated onto the ultrasound image. And a very similar concept to what you saw with the GPS system. This is how it works. And this is an image of the video of the subclavian being cannulated. So you can see it's very easy to aim and shoot. So I'm running out of time. I'll just quickly tell you about this new system which is still not commercially available. It's called an optical tracking system. Now it involves just a stereoscopic camera which can clip onto your probe, and what it does is it actually looks at your needle. It takes the video feed of your ultrasound image and interpolates it onto how it thinks the needle is moving around. Okay, so I'll just show you a quick product video, and you see that all you have to do is clip it onto the probe, and you get a similar sort of picture which you have seen. You can can see the needle trajectory here to the target. This again works, all these guidance technologies are very similar in what they're trying to achieve. They're trying to point you in the direction by creating a virtual needle and eliminating the skill component required for the regional tracking. So the advantages of this is you can use it with the conventional needles and you can clip it onto your existing machine. You do not need to buy a new probe. It's still not approved, but I think it should come around. In conclusion, it's restricted. Not many people have these machines, especially the GPS kind of machines. So unless everybody gets it, it's not going to get very important. It's unproven whether this actually improves patient safety. It's just there. Logically, it does look like that, but we still have to prove it. Again, do we change our concepts of anesthesia and in regional anesthesia with these machines? And are we going to lose the skill and challenge? That's something we need to think about. Thank you.
Thank you, Dr. Amjad, for the elaborate explanation of all the techniques. I don't know how many of us will have to acquire it. It's one of the costliest instrument which everybody may not, at least the government hospital may not be able to avail it. I don't know how soon it will come and how much it is beneficial over the other technologies which are available with us and quite successfully used. Thank you, Dr. Amjad. We'll have the question answer at the end of the 4th lecture. Yes, please.
Yeah. So the next speaker is Dr. Manoj Karmakar from Hong Kong, and he would be speaking on stimulating catheters, 3D and 4D ultrasound technology.
Thank you, Chairman. Good morning, ladies and gentlemen. I think Sanjay has already spoken about stimulating catheters, and in the 15, I think it's 15 minutes, sir? The time?
No, I think.
Yes, thank you. Dr. Mahajan is not here, so it's more than 10 minutes. Right. I changed the title a little bit because I think we want to make it more clinically relevant to the situation. And I'd like to show you how high-definition ultrasound imaging is influencing our practice of regional anesthesia. As you have seen some futuristic technology, this is technology we have available today. Yes, it is exorbitantly expensive. It is in a research phase, but I have no doubt that in the future, this is how we will be doing nerve blocks more objectively, and this is my goal. So, at the Faculty of Medicine at the CU, we are fortunate that we have lots of research funding and we have been able to acquire this. So this equipment through these funds. So anything I say will not be will be influenced by the companies or any conflict of interest. I have nothing to declare. But I have to say that some of what you will